Hello and welcome. My name is Joe Saramelli, and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. And thanks for joining today's Grand Rounds presentation. Now, for this academic year, we're trying to have a theme for the series called Next Steps in Care, which I think it does go along with today's presentation. Next steps in care in training clinicians for suicide prevention, for example. Now, there's a core group of us who work on Grand Rounds each week, including Samhara Braha on communication and coordination, and Mike Walker on technology. We do archive our presentations on the Grand Rounds website. Funding for a Grand Rounds series from the Ripley Fund and from institutes in the department, such as the Garvey Institute for Brain Health Solutions. Now, close to the end of the presentation, I'll put a link for a Grand Rounds speaker evaluation in the chat. It's 5 or 6 questions long. Please complete the evaluation. That's helpful for me to see for planning Grand Rounds series and for communicating with the presenter afterwards. And now for today's presenter. Today we have Dr. Doyen Darnell. Now, Dr. Darnell is an assistant professor here in the Department of Psychiatry and Behavioral Sciences at UW. Dr. Darnell currently works clinically at Harborview Medical Center and is Director of Psychological Services at the Harborview Mental Health and Addiction Services. Dr. Darnell has developed a clinical and research interest in acute care, post-trauma care, and suicide and trauma prevention. One way Dr. Darnell approaches these areas is through clinician training, which is an area we will hear more about today. Now, just a brief background on Dr. Darnell. Dr. Darnell completed doctorate in psychology in 2012 at Georgia State University, and then accepted a T32 funded research postdoctoral position here at the University of Washington. Dr. Darnell then moved into a faculty position and has worked on several research studies, such as in post-injury care. And more recently, Dr. Darnell competed for and received a K23 grant from the NIMH to advance Dr. Darnell's expertise in suicide prevention training. Now, I'm very glad Dr. Darnell has agreed to present today, and I'll pause there for now and turn it over to Dr. Darnell.
Thank you. Thank you, Joe. Just getting my stuff set up. Good afternoon. I'm Doyen Darnell, clinical and community psychologist and mental health services researcher. I'm interested in how our healthcare systems can deliver high quality, patient-centered, evidence-based interventions to a greater proportion of the population in need of behavioral health services. And I want to start by sharing this artwork that illustrates for me why I do this work. This is a painting by Jen Hem. It's titled, "It Takes a Village to Heal a Trauma Survivor." And it was featured on the cover of the American Psychologist several years back, which is how I found it. The artist, she's expressing an aspect of her experience in trauma recovery here. She's featuring herself as the white bird, and she's being held up by many different hands that represent to her the people who played a role in her recovery process. So this artwork hangs above my office desk as a constant source of inspiration and reminder of the diverse roles that we can all play in supporting the health and well-being of our patients and as members of our community. And this is really what my work's about. It's about how to support healthcare providers in taking on novel activities or shifting roles so that we can engage patients in brief interventions that, despite being pretty brief, can be really helpful. So throughout my talk, I just want to make the point that I will use the term healthcare provider quite broadly to mean any type of role in which a clinical service is delivered to patients. As a clinician, like Joe said, I work at the building on top there. That's the Pat Steele building on Harborview's campus. And my focus is on supporting trauma survivors in their recovery as a psychotherapist. And I also advise in efforts to implement evidence-based psychotherapy clinic-wide. But my research is going to be the focus of this talk. And this has predominantly been in the acute medical care context and exploring opportunities to improve services for trauma survivors early after a traumatic experience like a sexual assault or a serious injury. And I've done work in alcohol brief intervention, early interventions targeting post-traumatic stress and depression, and more recently, suicide prevention. For this talk, I'm going to share a little about a current research project I'm working on that harnesses artificial intelligence technology to train nurses to do suicide safety planning with hospitalized patients. But I will illustrate the benefit of this technology by using research on alcohol brief interventions. And what I hope to leave you with today are these take-home points. Brief behavioral health interventions are an important part of the continuum of care, and that the intervention quality matters. Evidence-based training and the quality assessment is hard to do. And so novel technologies may really help us overcome these barriers. And first, I want to define some terms I'm using. I like this definition of behavioral health, which is the full range of mental and emotional well-being from day-to-day challenges of life to treating mental health and substance use disorders. And when I use the term brief intervention, here's how I'm thinking about it. I'm talking about the amount of time the intervention takes. So of course, this is going to be brief, but brief could be 15 minutes. It could be an hour. Usually refers to one interaction with a patient, but it could include one or two additional interactions. But I'm also talking conceptually about the role that it plays relative to treatment. So brief interventions are distinct from treatment, both in the intensity of the intervention. For instance, treatment could be months or years, but also in the level of severity of the condition we are intervening on. So an example might be the distinction between a one-year treatment program that helps somebody who's dependent on alcohol to stop drinking versus a 15-minute counseling session, inviting someone who's drinking, let's say 4 to 5 drinks on a Friday night, to consider drinking half that amount instead. And when I refer to brief interventions, I'm primarily talking about the area here in this figure on the spectrum having to do with prevention. But it's important to remember that when we're talking about prevention, selective or indicated prevention, they refer to intervening with people who are at risk or already showing signs of a condition that may end up actually needing treatment. And I also want to say that you can have a brief intervention that's part of a treatment program. So oftentimes you'll see that as an initial step towards treatment. And they're often embedded in service delivery models that make this distinction very explicit between low and high intensity care. So an example is screening brief intervention referral to treatment, or SBIRT, which is popular in addressing substance use problems. And in this model, we screen patients to identify what their risk level is, the severity of the problems they might be having with the substance use, and then deliver a brief intervention that fits what they need based on what we've observed. And so for patients with more severe treatment needs, or where their use is more severe, we might make a referral, and you can actually have a brief intervention that's really designed to encourage people to follow up on a referral. But often we're talking to people about reducing risk or reducing harms associated with substance use. Stepped care is more commonly seen in mental health, and you would assess patients again for risks or kind of this stage of their condition that the condition's in, and then you'd offer a level of care that is most appropriate for their need. So if the lower intensity care does not address the need, then patients can be stepped up to a higher level of care. And then quality is going to be the key cornerstone here of my talk, so we want to make sure to define that. When it comes to assessing how well we are implementing evidence-based interventions, I actually prefer the word quality. And I like this definition from Fairburn and Cooper. And the definition is the extent to which an intervention is delivered well enough for it to achieve its expected effects. So we're looking at what we do and how we do it is going to get us to our patient outcomes that we and our patients want. So it's very explicit in linking what we do and how we do with the outcomes. And one way to think about this too is that if we're getting good outcomes that both we and our patients want, you can kind of assume that we're doing this well enough. And so this is usually the first step in doing a kind of a QI or a quality improvement approach to care and trying to understand how well we're doing. I first got interested in this line of work during my postdoctoral fellowship at UW, and this was in mental health services research, which I did start in 2012. And I was working on a team with the then clinic director, Lucy Berliner, of what was then called the Harborview Center for Sexual Assault and Traumatic Stress. And we were working on finding ways to improve the rates of victims who sought emergency services at Harborview after their sexual assault to then attend a free follow-up appointment that's offered at the clinic. So there's that clinic below that's also Pat Steele. So it's not in the ED, which is nice. It's at a follow-up clinic nearby. And this is a free appointment that has medical purposes as well as psychological purposes. And what we found was that most patients did not attend the follow-up. So that's what I was there to do with Lucy, was try to see if we could improve that. And we did document that the follow-up rate was not what we wanted. And there was very few people who were actually engaging in ongoing psychological services. So we didn't know how many people sought services elsewhere, but we know from other research that people tend not to obtain services right away, and unfortunately can go many years before seeking help. And this is absolutely not a problem that is associated with just sexual assault. This is well known that at a population level, people who are experiencing behavioral health conditions that would likely benefit from treatment, they are not receiving this care. And there are racial and ethnic disparities in who receives care. These figures are from the Substance Abuse and Mental Health Services Administration, their annual national study of behavioral health services. I took them from 2 different years because I liked the 2 different figures. But one on the left side kind of shows you that we're getting half the people into mental health care who have mental health conditions. And then the other one on the right shows you that we've got 10% of people aged 12 and over who have an alcohol use disorder are receiving treatment. So despite the fact that I work in a specialty behavioral health clinic and it's very busy there, and there is a long wait list for psychotherapy right now, particularly, I came to understand that at a population level, we aren't reaching the population in need. And I became interested in models of service delivery that aim to provide some degree of services for patients where they are already presenting. And I really like brief interventions because it's something we can generally do in the immediate for people. And this kind of reach is important in reducing healthcare disparities in healthcare services. As an example, let's take a closer look at brief interventions within the context of ESPR for alcohol. And ESPR for alcohol does have the strongest evidence base. In the ESPR model, all patients presenting are given a screen presenting to a care setting, and they're given a screen to determine their risk level or likelihood of experiencing problems related to alcohol use. And like I mentioned, they are provided a brief intervention or a referral for treatment depending on their screening results. And so the implementation of ESPR can have just a brief one-time intervention, but some of them also do like a brief treatment model where you might get a few sessions of counseling with a ESPR counselor. But the main innovation here was really in identifying people outside of the 5% at the top of the triangle there who would normally be referred for treatment. I mean, the traditional approach has been to assess and refer patients for treatment. But in this case, what we're finding is the 20% of the selective or indicated groups, and we're offering them a brief intervention that they wouldn't have otherwise had. And so this is a real value. And I love to highlight that Harborview-based research has led the way in trauma center alcohol brief intervention. So ESPR and alcohol brief interventions, they've been under study for 40 years and more than 40 and implemented in a variety of settings inside and outside of healthcare. But in the mid-1990s, a team of researchers at UW led by Larry Gentilello and funded by NIAAA, this team conducted a randomized trial with 762 Harborview inpatients. And this was a very important trial in the history of trauma center alcohol brief interventions and led to some important policy recommendations around delivering these in trauma centers. And the team psychologist, Chris Dunn, he was the one who trained me in alcohol brief interventions and trained me in how to train others. He was the interventionist on this trial. And what he did is he did a 30-minute intervention with patients determined to be at risk. And they measured that using a combination of blood alcohol upon admission to the hospital and also a self-report measure of alcohol use. And so he did this intervention with patients who were at risk. And this is associated with 15 fewer drinks per week over 12 months. Now, you didn't actually see that size of an effect until the 12-month follow-up. People sort of reduce their use after an injury naturally. But that was based on self-report. And then there was an important finding about reducing the risk of re-injury by half over 12 months based on hospital records. And that was not statistically significant, but it was a meaningful effect in the sample and was also pretty persuasive for the value of these interventions. But what goes into a brief intervention like this? This motivational interviewing-based counseling session started with feedback to the patient on their level of alcohol use or alcohol in their system. And then that led to a discussion about exploring reasons for changing drinking patterns and behaviors, maybe even developing a plan for doing so if the patient was willing. And I really like this definition of motivational interviewing, which is a person-centered counseling style for addressing the common problem of ambivalence about change. So this style is empathic, it's collaborative, it avoids any confrontation or judgment about the patient's use or behavior. And it's very similar to, this patient-centered counseling style is what was used in Dr. Dunn's brief interventions. It's also what you see in psychotherapy around these common factors and the kinds of counseling styles that are really important in observing change in our therapy patients. And you also see that these patient-centered counseling skills are really important even in delivering psychopharmacology. So I'm particularly interested in these skills in my research. And that's really great, right? So when Dr. Dunn does this intervention, it's effective and it's improving people's lives, but you kind of want to know, well, what happens when we take something like this to scale and you are not using a highly trained interventionist to do all of the interventions? In May of 2009, a team of researchers at UW led by Doug Zatzig and funded again by NIAAA and included Dr. Dunn as the trainer. And in this study, he's in the trainer role, so he's not doing interventions. They conducted an effectiveness trial that took the intervention to scale by training frontline trauma center providers. And these were mostly nurses and social workers, and they were doing the alcohol brief interventions. And so there were 20 sites randomized at the site level, and 10 went into the training intervention arm. And so what we have is we have 10 sites where Dr. Dunn is going to train all of these clinicians, providers in doing alcohol brief interventions according to the way that he was doing them in the previous study. So I joined this team after the trial was over to take a closer look at the data with them, the training data. And I want to say that the training model was really derived from the research and what is known about evidence-based training. And, a key thing in evidence-based training is basically having the opportunity to practice skills and getting feedback on your skills performance. So 16 trainees were in those 10 sites, and they all did a one-day workshop with Dr. Dunn to get the basics down of the skills, but then they got a chance to try out their skills in role plays and get feedback on them over the next 6 months. And then also over those 6 months, they attended 4 coaching calls with Dr. Dunn to get tailored help and support. On both arms, you have the training arm and sort of the control condition. Everybody is doing role plays as part of the evaluation and as part of the study design. And so you have 7 role plays total over 27 months for all of the providers. But those in the training group, they got feedback on those first 4 role plays. And each role play was observed by a member of the research team that's trained to rate these for quality according to the principles of motivational interviewing. And in this way, we could see the impact of the training on the skills that are considered essential for effective brief interventions. And I want to tell you a little bit about the rating, because that's a really important part of this process. So in order to do this rating, you have to have a trained rater who listens to the role play and then documents their scoring of the quality of various provider skills. It's also a lot of work to get a trained rater. So, if you have an MI expert who is not doing the rating, then other raters have to be trained. And in fact, for a clinical trial, it's customary to show that your raters are well trained and can rate reliably in sync with each other. So this is a lot of work, and you're coding hundreds of sessions. The trial used a very common rating system known as the Motivational Interviewing Treatment Integrity Scale, and this includes ratings that have to do with the overall impression of the provider's skills and style in the role play, as well as very specific skills used throughout the role play at the utterance level. And I'm going to show you examples. So for example, a rater would give a score to rate the overall impression of how empathic the provider was over the course of a 20-minute brief alcohol intervention role play. And like low empathy might be considered the provider has no apparent interest in the patient's worldview, gives little or no attention to the patient's perspective. And high empathy, provider shows evidence of deep understanding of patient's point of view, not just for what has been explicitly stated, but what the patient means and has not yet said. And the idea is that you want to get a 3.5 on this scale to be at kind of a basic level of MI proficiency, and then 4 or 5 is good quality. Here's an example of an utterance level, what you might rate as a reflection. So I have a standardized patient who had been driving and got into a motor vehicle accident and had been drinking alcohol earlier that evening at a party. And what she says is, I tried to self-assess to make sure I was clear to think, but maybe I wasn't self-assessing very well. And then the provider who's doing the role play says something like this: that sounds like it's something that is important to you. You want to be responsible. And I can also hear some doubt in your voice that you're thinking, maybe I wasn't at the point that I should have been driving. So reflections are an active listening skill in which the provider communicates that they are understanding the patient by reflecting back what the patient is saying or meaning. So it is an indicator of empathy also. And this kind of thing, you want to see more of in an MI session. We presented the data in our paper at the individual level because, you could see we have 16 providers. It's not a lot of providers, but it's really compelling when you look at the data visually. So for example, this graphic depicts the findings for the global scale of empathy, and the scores, they do start, this is after the workshop that you're seeing here. So they've been trained, and you can see that the control group in red was at the level 3. Whereas the train group in blue was at the level 4 after the workshop. And then scores went down a little bit over time in the trained group, but are still at what is considered by the MIghty cutoffs to be at a basic level of skill. The findings from the clinical trial found that 8% fewer patients enrolled at the sites that received the evidence-based training met criteria for drinking alcohol at a hazardous or at-risk level by the 12-month follow-up. And this is based on self-report responses to a measure of alcohol use problems. And then the MIghty scores for providers based on their role plays actually mediated the effect of condition on the measure of alcohol use over time, suggesting that the higher quality skills accounted for this difference. So what we learned from this study is that training frontline trauma center providers to deliver higher quality alcohol-free interventions leads to improved patient outcomes with a meaningful impact when you consider it at a population level. And I'm not going into the details of all the training outcomes, but I will say that we also found that the global skills in the patient-centered counseling were sustained over the course of the 6 months of training on average, with a modest drop-off after the training. So evidence-based training matters, but there are still pragmatic concerns. If we take a look at the training model here that we just described and the quality assessment that was deployed in this effectiveness trial, we are asking for a lot of resources. So you've got to pull your providers out of their clinical duties to train them. You need an expert trainer who's going to do a one-day workshop with all these places. You might be able to centralize that. But that wasn't how it was done then. And then they've got to provide this individualized coaching and feedback, and you need trained standardized patients to do role plays and raters who can rate all those role plays. In another collaboration with Dr. Zatzik and his trauma survivors outcomes and support team, I led the training in brief behavioral health interventions for frontline healthcare providers in a 25-site pragmatic clinical trial. And this trial was funded by NIH. And this time we deployed a more pragmatic training model. And it actually included alcohol counseling within the context of a stepped collaborative care intervention that targeted multiple concerns of patients after an injury. And the primary target was actually post-traumatic stress symptoms. But nearly 30% of the enrolled patients had a positive BAC at admission, and alcohol use was a secondary outcome. The trial did not find an impact on alcohol use. Now, in this study, all the sites eventually went through the training as part of a stepped wedge design. And so we trained 25 sites over 2.5 years in the stepped collaborative care intervention. And we had 1 day for the workshop that covered the entire intervention, which meant 2 hours to teach providers skills in alcohol counseling. And then the idea was that providers could get the opportunity for more tailored coaching and some feedback embedded into weekly meetings that they would have with Dr. Zatzik and the intervention supervision team, if that was something that was indicated for their patients. For this training model, I really emphasized the patient-centered counseling style, and I wanted to maximize the use of my time. And so what I did is I didn't teach motivational interviewing per se. I taught patient-centered skills. And I used a framework that would be really consistent with healthcare settings. And this framework is provided by Mead and Bauer. And they have a definition of patient-centered care that is providing care that is respectful of and responsive to individual patient preferences, needs, and values. And it really ensures that the patient's values guide all clinical decisions. And I just think patient-centered care is a great concept to utilize because this is something that all hospitals are pretty much, on board with. It's in the lexicon. And so I took their paper and I, tied the MI skills to these different dimensions that are available in their paper. So since time was short, I only spent a quarter of the time on what goes into a brief intervention and the rest of the time on how to do this in a patient-centered way. And I used an experiential exercise to kind of get providers to take on the patient perspective very quickly, because we all change behavior. We know how hard it is to change our behaviors. And so we can use our own lived experiences to think about what would be helpful in helping other people make changes and how to talk to them in an effective way. So we again used a 20-minute role play to assess provider skills in this study, but we only used this for the study evaluation purposes. We did not use this in the training. And we had 2 female research staff who were trained to be standardized patients. One staff member was always the pre-workshop SP, and then we had a different staff member who was always the 6-month post-workshop SP. So the SP, or I'm calling him the SP, but standardized patient, would call the provider and do the role play over the phone and record it. And at the end of the call, she would rate the provider using a pragmatic measure called the Behavior Change Counseling Index. So I want to show you what that is. It's a very brief measure that was created by Stephen Rolnick, who's one of the developers of motivational interviewing and co-developed with Claire Lane at the University of Wales. And the idea behind this measure is that it takes much less training and time to use and is specifically tied to what is called behavior change counseling. And behavior change counseling is entirely consistent with motivational interviewing and patient-centered care, but it's just really highly organized around being brief and to be done specifically in healthcare context. And so it's about helping patients talk through the way, how they're going to make change, why they want to make change. And it focuses less on these really sophisticated skills that MI often teaches for resolving ambivalence about change. And one example item that is consistent with that empathy construct we were talking about earlier is the practitioner uses empathic listening statements when the patient talks about the topic. Because we had recordings of the role plays, we were able to do a sub-study showing that this measure correlated well with indicators of motivational interviewing. And using the role play ratings on this Becky, we found that the 6-month post-training standardized patient actor rated the role plays more consistent with behavior change counseling than the pre-training actor did. Now, this analysis only uses those folks who had ratings for both role plays. This effect size is small, and it might be qualitatively the difference between doing behavior change counseling to some extent versus a good deal. We also did not find evidence that the weekly coaching calls impacted skill improvement in alcohol counseling, and this just might be due to the modest amount of time spent specifically on coaching around alcohol counseling. And these were pretty jam-packed sessions with lots to cover for these providers. So we didn't give feedback on role plays here. And my first thought is, well, that would be the next step, right? So that's normally a part of evidence-based training models. And we might have had a greater effect if we had given feedback. But we were also interested to see if this varied by type of provider, since we did have some people who were more seasoned in brief alcohol interventions in the sample. All of these sites, have ongoing alcohol brief intervention services, and some folks, were those folks who were from their alcohol brief intervention services. And then there were some folks that were completely new to it. And we didn't have enough sample size to look at the difference over time by group, but we did look at everyone who did a pre-training role play and everyone who had a 6 months post-training role play. And so you can see our sample sizes here show that we did have fewer people at the 6-month follow-up. But the figure shows what we might expect. We've got people with a behavioral health background for whom counseling is traditionally associated with their training. They had higher Becky scores. And so it might be that our training had more of an impact on people without that background. And I think this data makes the point that behavior change counseling training or patient-centered counseling training is really important. Healthcare providers are on the front lines of helping people make changes in their health behaviors. So it's really important that we're able to effectively counsel patients about all kinds of behaviors. I do think alcohol counseling can be particularly challenging for providers because I think it triggers emotions that can interfere with the counseling style that we're looking for. I don't think it's intentional, and I think training can really help people with this. So I wanted to show you an example of some script that kind of depicts something like that. Okay, so we have the same standardized patient as before. And this is this patient who was in a motor vehicle accident after drinking alcohol at a party. And she says, I tried to self-assess to make sure I was clear to think, but maybe I wasn't self-assessing very well. And this provider says, are you open to any community resources for helping out with potential drinking and driving and safety courses or something like that? Standardized patient says, no, that's not something I'm interested in. Is there a reason why? I mean, alcohol may have played some role, but I think it has a lot to do with the fact that it was late and dark. Nothing like this has ever happened before. I just don't think it's quite that serious. And the provider says, I would really encourage cessation of drinking and driving and some additional education, because what if this car accident had worked out differently? What if you were in an intensive care unit and you had some family members at your bedside that were extremely worried, thinking you weren't going to survive? Would that be something you would be able to live with? So unfortunately, oops, sorry, I did not advance that for you guys. There you go. So you can read it while I explain a little bit more about that. Unfortunately, the data shows that this kind of counseling style is actually associated with a lack of, or even worse, outcomes for patients. It can actually cause harm. But more likely, if we are doing the intervention without adequate quality, we may be wasting resources. And I think one way to see what's happening here is that the provider is really concerned and thinks this patient is a potential risk to themselves and others, and there may be fear coming up, or a sense of urgency, or maybe some anger about the risk to others, which is understandable. We don't know the background of this provider. They could have experienced an accident like this. And I think we can sympathize with the provider, and we are equally concerned. But the patient is saying they don't see things the same way. So what ends up happening is the provider is trying to get the patient to see how serious this could be, and using confrontation because of the urgency they feel. But confrontation is just more likely to put the patient off, close down the conversation, and there are other ways to express concern that's patient-centered, and that's what we cover in a training, is to help people deal with their reactions and offer alternative strategies to confrontation. I think these studies on alcohol brief interventions really nicely illustrate a theme in the research literature, that when we move from efficacy-oriented research to pragmatic studies, we lose impact of the intervention. In an efficacy trial and even some effectiveness trials, researchers are tightly controlling the intervention, and they will be monitoring the quality of the intervention. In efficacy studies, your providers are going to be trained up to a high standard of intervention delivery. But once the trial moves out into that pragmatic area where we're trying to study if the intervention works in the real world, under real world conditions, with real world resources for training and quality monitoring, which usually means pretty modest and no quality monitoring, modest training, we see a diminished relationship between the intervention conditions and the outcome. And of course, there are multiple potential reasons for this, like you are going to have more diverse patient groups in a pragmatic trial. And when you see a greater diversity of patients, you can imagine that you might have an overall effect attenuated. But it is really likely that one reason is that there's more variability in the skill of providers, and the intervention may simply not be delivered at high enough quality level. So the issue would be not that the intervention doesn't work, but that the intervention delivered at a lower quality level doesn't work, which is totally expected. But if we don't measure this, we won't know. I hope that I've made the case that quality of our interventions matter, but also that it's really hard to pragmatically assess the quality, which can be a barrier to carrying out our evidence-based training models. And trainees need opportunities to practice skills. They need role plays, they need feedback, and it can be really challenging to do that in a pragmatic way. And I call this a need for provider-centered training for patient-centered care. So let's take a look at the potential of novel technology to help us with this. At the same time that this 25-site TSOS trial was being implemented, I learned about the novel research going on by David Atkins at the University of Washington and his NIAAA-funded team to develop computer-based automated procedures for rating the quality of motivational interviewing counseling sessions. And this sounded like just the thing that could help us roll out training for patient-centered brief interventions in acute care. Their team developed a computerized system that can take the audio of a recording of a role play or real patient interaction, convert it to a transcript, and have the computer rate the transcript. And they also do some work with audio, but the majority and what I'm working with also is the text. And this is made possible by awesome advances in speech signal processing, natural language processing, and machine learning, which have all considerably advanced in the past 15 years due to increases in computing power. Now, computers have been used a long time to analyze transcripts, and they could do the things that were hard for humans. So like finding and counting up words or phrases, this was pretty common. But it's only with the innovations in machine learning that computers can now be taught to do a task that used to be so complex, only a human could do it. So, take something like empathy, for instance. How can a machine know what empathy is? Well, if you show the computer many examples of text that are rated for empathy by humans, the computer can learn which features of the text are associated with low to high ratings of empathy, and then use that information to rate novel samples of text. So Dr. Atkins' team has shown that they can do this for a variety of important MI metrics in a way that is reliable with humans. And they've developed a platform called Listen to facilitate giving feedback to trainees based on the automated ratings. And this includes the option to review your audio or video of the transcript and the transcript of the interaction. So this basically alleviates the need for a trainer to review audio and give feedback. And it replaces the need to have trained raters to do the rating. Huge, huge benefit. And this feedback is so highly accessible. It's available on the internet in minutes after uploading and recording at the push of a button. And what I love is that it can be confidential, which I really think is important to create this safe space for trainees to practice. And so it can be set up that only the provider sees their role play and feedback. In 2019, I was funded on an NIMH Career Development Award to study how to apply this technology in the acute medical care context. And instead of using it for brief interventions, we learned on the TSOS trial that there was a great need for addressing suicidality in acute care. And I sought to deploy the technology to train hospital nurses in suicide safety planning. This project is intended to develop a training that can be integrated into routine workflow, and it is made possible by a really large team of mentors, consultants, advisors, and staff, including members of the Listen team. And I'd like to give a special thanks to Kate Comtois, who's my primary mentor in the project. Project WISE takes place at Harborview Medical Center in Seattle, Washington, which as a trauma center and a social safety net provides services for patients at greater risk of suicide than the general population. And recognizing this risk, Harborview has adopted the policy of screening all patients entering acute care, including the emergency department, and medical, surgical, trauma, injury patients. They're all screened. And then patients who are identified at high risk are referred for psychiatric consultation. My premise is that nurses who are already screening for suicidality, working closely with patients and helping patients prepare for discharge from the hospital, they're ideally positioned with some additional support and education to engage patients in a brief suicide prevention intervention. So although you have higher risk patients who might be referred for outpatient specialty care, as we've seen, there are barriers to receiving or accessing such care. And for many patients, the services rendered in the hospital may be all they receive. The intervention we are studying is based on the Stanley Brown Safety Planning Intervention. And this is a recommended intervention by the Joint Commission with the organization that accredits and certifies healthcare organizations nationally. And it does require patient-centered counseling skills. This has to be done empathically, collaboratively, and non-judgmentally. I'm not going to go too much into the intervention just for the sake of time, but I will say that it was originally developed as a part of treatment. So it was a brief intervention used during treatment to help patients get safely through a crisis. But it's been studied as a standalone brief intervention and now disseminated quite widely as such. We've put together an e-learning experience that can be broken up into pieces. So nurses could do portions of the training whenever they have time to do it. Or, it could be that it's lumped into a one-time 6-hour training or a 3-hour chunk of training. This particular model is intended to take 3 hours, and nurses in our state do have to take suicide prevention training. So that may be something we could deploy it for later. What we start with is, a basic webinar that we would train people in skills and show them skills through didactic and demonstration using stuff that's all free on the internet and available. And then they interact with a chatbot that was developed by Mike Tanana at the University of Utah and Listen. And this is a conversational agent where nurses can practice micro skills of asking open-ended questions and making reflections. And then they role play with a patient actor, a standardized patient. That role play is fed into the Listen platform, and then nurses are asked to review it and review feedback related to the empathy skills and doing this collaboratively. So right now we're only working with those particular skills. But we're going to learn a lot about how the measurement of patient-centered counseling skills that was kind of originally designed with motivational interviewing, how that maps onto safety planning. But we are also using user-centered design and implementation science to study and conceptualize how best to integrate this technology into a flexible e-learning model with the acute care context and acute care nurses. And we are amidst an evaluation right now deploying this training with nurses at Harborview. So I hope that what I've left you with today is this idea that how we do what we do is as important as what we do. And that I've illustrated how novel technologies might be able to help us with how. But I cannot ignore that we are working in unprecedented times in healthcare. This article from The Atlantic is one of many examples of articles coming out about the challenges our healthcare workers are dealing with. And in some ways, getting folks trained in suicide prevention skills could be a real positive thing to help manage the stress of working with these patients. In other ways, it could be that it's adding stress to ask people to take on novel responsibilities. So we're thinking about that. But the other point I want to make is that ultimately the time saved through efficient and effective training models, it's about being responsive to the needs of healthcare workers in a system that's very demanding. And it's really important that we don't forget that the most critical resource healthcare workers need is adequate time with their patients. And I regularly hear that providers don't have enough time. Adequate time means time that providers can really be with their patients and have the ability to focus on delivering patient-centered, evidence-based care. So we're talking about quality time, even if it's just a few minutes. Evidence-based training is necessary, but not sufficient. And it may not be of much help if we are in an exhausted system. We really do need to be concerned about the well-being of our providers, as well as our patients, because we are each other's village. Thank you.
Well, thank you, Dr. Darnell. Very informative to look through some foundational trials on the topic, how your research evolved from that, areas you've focused on, and more recently what you're doing within the Harborview Medical Center here. Thank you for describing all this. Now, I'd like to encourage any participants to write in with questions, comments. We have about 10 minutes, so there's time to go through, many. So I guess, Dr. Darnell, as people are writing in or thinking of what to ask, I'm curious, one of the things you said early on, you think about intervention quality, and I assume that was instead of fidelity. Is that right? And if so, why? Why should we think about it as quality?
Yes, I love this question. I think of fidelity as a concept that is very similar to quality. Obviously, there's lots of overlap, so it's kind of fine to use that word. But fidelity is really about models that were tested in efficacy studies or effectiveness studies. They're really about adhering to a model that the evidence is based on. And I think a little more flexible approach says that what we're really after is doing things well enough that they approach that outcome, as opposed to focusing on just adhering to a model. And that's also because we don't often know which pieces of the model are really the cause of the effect, right? And so we're constantly learning more about that. And I think the idea of quality keeps that ever present in our minds, that we often don't know what's causing these effects. And the mechanisms research is very important nowadays. And I really support that, because I think we need to know which piece of this model is the most important piece. Mm-hmm. And I would say the patient-centered counseling skills are always going to be an important piece. Yeah.
It's very interesting. It's more in line with how we think about clinical care delivered as quality rather than a fidelity type mindset. It's interesting.
Yeah.
A question came in. What's it like for people? What do people tell you? How do participants respond to feedback delivered by AI? Is it received positively?
This study hasn't gotten that far yet, but I would love to come back and share about data when we have it from my experience. But I think that, the preliminary work that Dave Atkins' team is doing, they are finding that people are enjoying it, responsive to it. I did some usability testing with some nurses who said they would like it. That they would be very open to it and find it interesting. It remains to be seen when we actually deploy it, if that stays true. Yeah.
Yeah. Maybe this will be informed over the next year, but as question is asking, thinking about the future, do you see this use of AI as a way to taking the place of patient actors, standardized patients, as a supplement to it, as a way to practice different skills? What do you think, to help with scalability? Perhaps?
I do. I sort of believe that the field of AI will continue to advance in remarkable ways, and that instead of doing standardized patients and training actors, I think we'll have avatars at some point, or virtual patients that can engage very realistically. Right now, the technology is not particularly well developed around the computer generating natural language. It's hard for computers to talk like humans and to create sentence structure and ideas and concepts like humans. But I know that will continue to advance. And so I actually foresee doing a lot more virtual patient interactions that are based on, conversations that feel very natural, actually. And I really like the natural language way of training, because I think people need to be able to say things in funky ways. We say stuff, it comes out of our mouths and we think, oh, did I just say it that way? Did I mean to say it that way? And you need practice with that. I think it's very helpful, as opposed to, say, when you do kind of like a multiple choice, choose the right thing to say for an empathic statement. I think that's helpful. That's a nice step. But it's really when we're in those moments where we're feeling kind of stressed out, under pressure, we have to think on our feet, and we generate something, naturally, that we need practice with that.
Mm-hmm. And probably with 4 or 5 people watching you in a hospital room, trainees, part of the team, family members, yeah, it can create some stress.
Exactly.
So I'm wondering, you mentioned about this at the end about healthcare workers in general. I'm wondering if part of the project you're working on with suicide prevention training, as you were describing towards the end, is this responsive to a request, or is it more of, I'm intending to train acute care nurses to do this? Who's open to it? Which is more accurate, or is it a bit of both?
I think, in this particular project, it's probably the latter, where there's an opportunity that I could see, and there is a mission of Harborview. This is a very mission consistent project. There's already, advanced screening going on. Harborview's leading the way in that effort. And so, there's already the recommendation to do safety planning. I saw that there's a wave going in this direction, and that there's an opportunity to continue to move that process along and to harness resources that already exist in our settings. And so this has been very developmental, very pilot. We're trying to find out, what do nurses want to do? Who would want to pick this up? And so we are seeing a lot of energy around that and interest. Whether that's something that the system can practically pick up right now is a good question. I think our systems are really under stress, and I don't know when that will resolve. But we still want to be making some progress on the research while we're looking for our footing again, or looking for our new normal. Yeah.
Thank you. Any other participants? We do have a couple of minutes if there's other questions or comments. I could ask another question as people are thinking of over what to write. What happens if a nurse identifies a problem that the nurse can't address, can't deal with, doesn't have the time? What's the next step?
In the current setup of services, yeah, I think that's another reason why this is a great project, because the system already has a lot of potential services and resources they can harness to help suicidal patients. So if you get in over your head, at Harborview, you have a psychiatric consult service that can come and support you. And the nurses have a provider team that they're working with and responsive to. Other hospitals, I have definitely seen in my experience nationally that what's available resource-wise for psychiatry, it varies widely. And that was also part of the reason why, I thought this would be a good project, is that there are places where there's just not a lot of support for the patients who are struggling with suicidality or mental health conditions in the hospital. So this might be a really nice thing in particular for those hospitals, but this is a great implementation question, which is, well, what do you do to make sure you're still supporting those nurses there adequately? Fortunately, at Harborview, we have quite a bit we have more resources. Yeah.
Well, that's very interesting. I mean, we're getting maybe a view of what some of your next ideas or next steps are, either clinically or with next projects. It's very interesting.
Thanks, Joe. Thanks for your questions. I liked them.
Yeah. Well, we have a minute or two. I don't see any new questions coming in. I do want to thank you, Dr. Darnell. It's seeing the trajectory. I'm hearing about sort of a sequence of research projects is often very inspiring for others to see. I appreciate you presenting this today, talking about what's happening now, offering to return to talk over results as well. It's really been informative, and I want to thank you.
Thank you. It's been my pleasure.
All right. Well, with that, we'll end Grand Rounds for today.